Hello, everyone. My name is Griffin,
And I am Daniel.
and we are presenting a case management study on a patient with diabetes who recently had an amputation.
The client is a 43-year-old male who is married and has two children. Believe it or not, even with this, he actually receives minimal social support. He has only been visited by his daughter once in the 49 days that he has been in the hospital. And his wife has not even reached out to him, has not visited him. He hasn't heard of anything from his wife in those 49 days. He is it comes from Hispanic community, and he lives in Valley Center. Um, he is of lower socioeconomic status. He really only speaks Spanish. He can get by with English, but um, just barely. He's not able to read or write either with either of them. His medical support is currently pending. He also has, besides diabetes, also alcoholism, and his current medical diagnosis is hyperglycemia due to diabetes type 2, that ended up resulting in an amputation of the first toe um, due to gangrene. The nursing diagnosis is ineffective self health management related to deficit in knowledge, economic difficulties, and excessive demands, as well as perceived seriousness. So the self-care capacity and treatment demands, believe it or not, this client is actually pretty well off. He can take care of himself. It seems to be that the biggest issue is he is not sure how to. He is able to bathe, dress, groom, perform dental care, eliminate on his own, walk, eat, and follow simple instructions. The only thing he really can't do is read. The deficiencies come into the knowledge when it comes to the actual infection, as well as the progression, as well as nutrition, and again, the alcoholism. So the treatment demands are just a little bit excessive for him.
All right, so getting into some patient priority issues for our discharge planning. So currently he's healing from his amputation site. So with discharge, he's going to need to have good, clean, proper wound care. He also has peripheral vascular disease secondary to his diabetes, so that's going to need to be managed. His diabetes has been ill managed in the past, so he's going to need education and support to manage his diabetes properly. He's going to need some support regarding his alcoholism. And lastly, his home is deemed unsafe by the social worker, so he's going to need some help finding a safe living environment for discharge.
And again, back to the fact that he has basically been deserted by his family with no ties or word from them. The discharge kind of becomes a little interesting. So he's not really sure where he can go or how he's going to go about doing it. He's not sure if home is a home anymore, not to mention that it has been deemed unsafe. So the options are something like getting affordable living through an apartment ways, renovating his house, or even selling the house that he technically is the owner of. Otherwise, he definitely needs assistance.
All right. So some strategies at the patient level and system level for this patient. At the patient level, our biggest thing is that we need to educate this patient regarding hazards that go along with his diabetes, as well as educate him on proper diabetes management. As Daniel said, this guy's smart. He's very capable. He just needs to be educated regarding what's actually going on, so that he can know the implications and take control. At the system level, he's going to need some help coordinating care. Um, so, yeah, we can't just discharge him and expect him to manage his diabetes well, given his past history of ill management. So we're going to need to follow up with him in the home with a community health nurse.
So interventions at the patient level, again, it sounds like it's pretty obvious. It's increasing knowledge on the control of diabetes, increasing awareness of hazards from the unmanaged diabetes, educating the patient regarding proper wound care, specifically to the amputation, and then greater than anything, instilling confidence in the client that the management of diabetes is doable and that he personally can do it.
Awesome. Looking at the system level, we're going to need to coordinate care to get a community nurse coming to the house. Ideally, it would be weekly for the first month and biweekly for the next 2 months after discharge. This will give the patient plenty of follow-up so that he can establish a good routine and have good practices to set him up for the long term. Some things that he'll be learning about are how to monitor his glucose, how to keep a glucose log, and how to manage his medications correctly. In addition, we're going to need to coordinate care with a social worker to help the patient find a safe living situation upon discharge.
So currently the utilization of resources by this client have not been too great. In fact, he has never obtained a primary care physician. And the 3 times that he has been to the hospital in the last few years have been his only times really ever going to a doctor his entire life. He said that he's gone a couple times in Mexico, but really he's never grown up going to the doctor or anything at all. So, and those past 3 times that we're going to the hospital were also acute exacerbations of diabetes. But now he is currently applying for Medi-Cal and hoping to get approved, being day 49 in the hospital. And the patient has also agreed to home visits from the community nurse once he has been discharged. So progression.
Great. So yeah, we have some quality and safety issues, especially looking at this patient's past. We're hoping to mitigate those looking forward. But some safety issues in his past is just a lack of consistent management of his diabetes, and also the unsafeness of his living situation. In terms of quality, same kind of stuff, just poor control of his diabetes. So that's why most of our interventions are aimed towards trying to improve this situation for this patient.
So nurse case manager effectiveness. At the patient level, the client has now begun to display progression on how to check his own glucose, administration of his own medications, even if it's just metformin, taking a pill at a certain time on a certain day. Proper wound care, since now he does have, an amputation, an open wound, as well as preventing that more necrosis from going on. On top of that, he has also mentioned the willingness to actually progress instead of regress. He doesn't want to lose any more digits, any more toes. He doesn't want to lose a limb. So that really, this whole incident kind of has freaked him out and got him moving a little bit. So he also does feel a little bit more confident in being able to manage his own diabetes. And a lot of that also had to do with the language barriers. So when giving it to him in more of his language, he's been able to be a little bit more receptive.
Looking at some of the outcomes at the system level, a lot of this stuff comes fully into fruition post-discharge, but that doesn't mean that the ball isn't already rolling on that. So in regards to the community health nurse, the case manager has contacted the county and has started the process of setting up a community health nurse with him. Looking at the patient, he states that he is willing to meet with the health nurse and work with him or her to improve his diabetes control. And then in terms of finding a safe place to live, again, the patient has agreed to work with a social worker to try and find a good, safe place for him to live. So both of those so far are partially met, and hopefully in the next few weeks will be fully met.
And our references.
Awesome. Thanks a lot, guys.